Transplants are not very effective in refractory disease. They are not very effective in certain biological subtypes of disease. So patients, for example, who have high-risk disease, for example, where on a standard cytogenetic, so this is the cells from their bone marrow are grown, and then the pathologist can look at what type of chromosome abnormalities there are. And if it's obvious that they have a deletion, which is a loss of a portion of the 13th chromosome, those are patients where they tend to be very chemorefractory. And for those patients, if they are doing well on their first-line treatment leading up to a transplant, I'm very hesitant to say to them, stop your first-line treatment and come to transplant, because we've seen some cases where the response to treatment has been lost during the transplant time. So patients, especially with comorbidities who are ill from other things or a little bit older or who do not necessarily really want a transplant, but are doing very well on their first-line treatment, if they have high-risk features that predict that a transplant may not be the best thing for them, those are patients probably left alone on their first line of treatment. And of course, as we mentioned, a transplant is not curative for most patients. This is the only data slide that I will show, and it's not my data. It's a publication it's a slide that I took from the Journal of Clinical Oncology recently. So what they did here was a number of transplant groups. Most transplant results are done by collaborative efforts between many centers, and these are studies where they will typically treat about between 60 and 200 or 250 patients, somewhere like that, and they'll follow them for a long time. And everybody's transplant program is the best in the world. It's better than the next person. It's kind of like, and it's hard to compare, because it's if one treatment does better than, if treatment A is better than treatment B, and treatment B is better than C, you cannot say that A is therefore better than C. It's kind of like filling out brackets for the March Madness thing. Because two teams play and one is better than the other, doesn't mean that the better team will always beat a team which the second team has beaten. How did I say it right? Or something like that. So when we pull different studies like this and we put them on one plot, the biostatisticians, they shirk a little bit, because we're not supposed to do that. But for some, for the purpose of illustration, what they did here was pool all the published clinical trials in transplant so that we can get some idea of what a transplant does for most patients. Some of these trials were studies in which patients got 2 transplants back to back. Some of them were studies in which they got 1 transplant followed by maintenance treatment with a pill, for example, thalidomide and so on. But it just gives us an idea of what to expect. The way this graph is drawn is that regardless of the number of patients in the trial, it was normalized to 100%. So we took every number here is converted to a percent. So for the purpose of this graph, every trial is starting with 100 patients. Every time that a patient is lost from any cause, it doesn't have to be multiple myeloma. Somebody walks in front of a truck, they still get counted as a loss on this graph. And so this becomes an overall survival. Every time you look at a certain time point here and trace it up, you can see how many patients in that particular study have been lost compared to the beginning. And they keep counting and so on. So if, for example, we wanted to look at a 10-year time point and say how many patients who started on this blue curve are still with us 10 years after the original study, they would go up, we would draw a line up to the blue line, look at it here, and we would say 85 or 90% of those patients are still here at 10 years after this study. I have to say this was a surprise to me, because in my personal experience, I think it seemed to me that these graphs were a little bit more optimistic than I thought at first. But as I looked at the data, I think it's probably real. And a large reason for it is the treatments that are now available for patients that relapse after a transplant. Several years ago, it was thought that a transplant is the ultimate thing you can do, because if somebody hasn't responded to 200 milligrams per meter square of melphalan, they are not going to respond to 4 or something like that. More recently, as these new treatments have come in, they've made a big and substantial impact in the treatments that are available both before as well as a transplant. So while many patients will need a transplant at some point in their treatment, it's by no means the only treatment they'll get, or even the treatment they'll get the best benefit from. We don't know, and it's very highly individualized. One way of describing these curves, because you can't paint these curves all the time, so biostatisticians define something as the median time of survival. So they'll take a curve like this, and they'll say at what time in this curve were 50%, one half of the patients still with us. And then you'll draw a curve, a line horizontally from here, and say 7 years out. So 7 years out, no, I think they flipped these two numbers. Hey, maybe I might get a letter to the editor out of this. But these numbers are flipped. So they'll draw a curve from the 50% level, and where it drops on the time curve would be called the median survival. And that's how to interpret these types of curves. So you'll see that the studies differ widely. Some of them, again, are single autologous, others are double autologous. Some of them, they had treatment after and so on. But the median survival, the time from when about one half of the patients have been lost from any cause. They could have had a heart attack, they could have died from myeloma, they could have died from complications of treatment or anything. That's about the time frame that this combination of studies shows. I think that was my last slide. Thank you very much.